introduced. I am a learning disability nurse. My background has been in brain injury rehab. I've been a district nurse, and for the last 4 years I've been also a practice nurse. Recently in my current practice taken the lead of supporting people within the practice with a learning disability and sort of implementing the care. I've got lots of other side hobbies and other jobs too, but I won't bore you with that information. So I'm just going to share with you my presentation, if that's okay, unless anybody has any straight off questions they want to get off the back. Equally fine if you don't. Just raise a hand if you have any questions, all right. So you'll have to bear with me because this is a long time since I've done a proper presentation, especially on Teams. So hopefully, can you all see this? If I could just get somebody unmute and say yes, because I can't see the screen.
Yep, I can see it.
Great, thank you. Bear with me. If anyone knows how to quickly open this up, I think it's that one there. Okay, here we go. So I'm Liv, I'm a learning disability nurse, and yeah, currently in practice. So this is sort of the agenda of the meeting. So I've sort of done the introduction of who I am, what is a learning disability, health inequalities faced by individuals with a learning disability, communication and communication needs, access to services and reasonable adjustments. So I thought we would start off with a quiz. If we open the chat up, we'll all go back to the main screen. Hopefully, I've set up a poll for us all. If it works, great. Otherwise, I'll have to do it my other way. But let's see if it works. So to start with, if you could all, has it all come up on your screens? Great. So what is a learning disability? Is it an impairment in intelligence that affects a person's ability to understand information, learn skills and cope independently? Or is it having significant difficulties in speaking, reading, reasoning, writing or understanding math and arithmetic? Have you all put your answers in? Wonderful. So I've had 6 responses so far. Anyone else? 8? A few more other people. Come on, only 9 people. There's definitely more of you on here than that. That's it, perfect. So the answer is number 1. So an impairment in intelligence that affects a person's ability to understand information, learn skills and cope independently. So we'll talk about more on this. This is just a brief quiz to get us all going. Then the next poll is, hopefully it should all come up. How many people in the UK have a learning disability? 1%, 2%, 5% or 10%? Oh, we've got mixed at the minute. Anybody else? Some people know the answer. Oh, we're a bit mixed. So the answer is 2%. So 2% of the entire population of United Kingdom should, or not say should, they have got a learning disability. So that's something really important for you guys to note for, that when you're looking at your learning disability register across your practices, that you should have 2% of your entire population. I've been doing a lot of work. I don't know if any of you have got Ardens, but Ardens have got Ardens case finders. And within Ardens case finders, it will highlight people that may have a learning disability. And you can find out if they're the rest of your population that are missing. You will find that we won't be able to pick up all of these people with a learning disability because they might be really, really mild. And they may just never have had a diagnosis. We'll talk more information about this though later. Okay, so the next one is, what services are available for people who have a learning disability? Now this should have been a multiple choice, so I'm not going to you're not going to be wrong on this one. For whatever reason, it didn't work quite like that, but just click on one and that's fine. It's just for everybody's information. Amazing. Any more responses? Perfect. So the answer is all of them. They're all available for every individual with a learning disability. So you've got the community learning disability team. We've got the learning disability and autism hospital liaison team. We've got social prescribing charities such as MenCap, Sense and Change. And then we've got specialist clinics for cancer, dementia opticians, dentists, breast cancer screening, a lot. And then final question. Now, I feel like you may be shocked by this response. I know Vicky was, and when I found this out, my jaw was on the floor. So what was the #1 cause of premature deaths of those who have a learning disability in 2021 to 2022? 80% of individuals died due to this problem or an associated complication. Have we got any answers back? Neglect, that's a big one. Anybody else? Common cold, sepsis. Any other answers? A couple more? Okay, I think that's everyone. Well, it's not, but we've got 9 responses. So the actual answer is constipation. 80% of people last year died due to constipation. Now, I don't know if you guys have heard of the LEADER reports, but any individual with a learning disability who dies will be referred to LEADER, and they investigate every single death. And that's to find out why they're dying prematurely. So yeah, quite shocking statistics, I think. At least definitely 80% of people dying because they are constipated. So I'll carry on the presentation. Can I just get if you can see this? Anybody just unmute and let me know.
Yes.
Yes. Great, lovely. So back to the first question. So what is a learning disability? So as we talked about, a learning disability is an impairment in intelligence that affects a person's ability to understand, learn skills and cope independently. The term a learning difficulty in the UK includes those individuals who have a specific learning difficulty, such as dyslexia, dyspraxia, dyscalculia, can't pronounce that one because I'm dyslexic, but who do not have a significant general impairment of intelligence. Now, you will find coded throughout your patient's records that they may have coded as a learning disability or a learning difficulty. Now, it's really hard to try and identify, do they have a learning difficulty or a disability? So there's a checklist that was created by Leeds and Yorkshire Partnership, and that's this inclusion tool on the right. There is a page 2, and I will send an attachment to this. I've also added this into IT through EMIS. So just to talk through it, it does say it's for GPs to sort of assist them. I do this in my practice, but it can be used with anyone. But generally, the feelers are if they've got an IQ of less than 70, then they've probably got a learning disability. And if they can answer yes to any of these questions, such as are they known to a learning disability service? Has anyone ever told them they've got a learning disability? Did the person achieve qualifications at school? So if they got GCSEs at low grades, it could indicate a mild LD, but high grade GCSE and A levels usually would suggest they don't have a learning disability. And they need somebody to help them read or write. And does the person have problems with simple numerical calculation? So if I gave you £5 to buy milk, the milk costs £1.50, how much change would you get? Quite difficult to go through this. I've spent the last couple of months working through our case finders through Ardens and noticed that a lot of the individuals that are coming through the Ardens case finders have been diagnosed with autism or Asperger's or are on the spectrum. And it's just a reminder that having autism or Asperger's is not a learning disability and have one without the other. So it's just something to bear in mind and something to just get checked. The most important thing to take home from this really is just to make sure that we standardise our coding across the entire England really, and we should be using on a learning disability or on the learning disability register, and that will get picked up in your QOF payments, but that's what we need, and that's what's picked up through your CCGs as to how many are on your register. Anybody got any questions whilst we're on there? Oh, I've skipped back. Let's see. Can you just unmute yourself if you've got a question? No questions? Okay, moving on. So there are a variety of different severities of a learning disability. You could have mild, moderate, severe, profound and multiple. And so this is sort of just a brief review of those different definitions, I suppose. So it can be difficult to diagnose even a mild learning disability, as the individual will often mix well with others and they can cope generally with day-to-day tasks, but they may need support in other areas of life, such as filling out forms. They may need support getting on and off the bus or accessing public transport, attending the doctor's surgery. So you might come across some individuals that actually haven't been diagnosed, but you may need to diagnose them because you've picked up that they do have a mild learning disability and they can access support through the services. Generally, people with severe learning disabilities or profound and multiple learning disabilities will need more care and support with areas such as mobility, personal care, communication, and generally they will have a support worker, carer, be in supported living, residential home. They will require quite a lot of support in these areas, but they don't all need support in every single area, just most of them. One thing to note though, when you're trying to find support with somebody with a mild, moderate, severe learning disability is the Community Learning Disability Team. Hopefully you've all heard about them. They have a strict eligibility criteria of who they cannot see, and that's generally due to capacity and demand. So their services are getting squeezed just like everybody else, and so they can now only see moderate to severe learning disabilities. You might not be sure if a patient will be eligible or appropriate for a referral into their team, but you can just give them a call, speak to one of the triaging clinicians. It could be a speech and language therapist, could be one of the nurses. You may speak to anybody really, and they can offer advice and support. It might be actually they're not sure themselves, so they'll ask you to put a referral through. They will go out and do an eligibility assessment, and then depending on that, whether they'll be accepted or not. The eligibility assessments actually really will say whether they have a learning disability or they haven't got one that is severe enough to require their services. Either way, if they have got one, it's one to code onto your records. We've got any questions? Again, just unmute yourself if you need to. Okay, we'll skip on. So there are a lot of associated conditions with individuals who have a learning disability. I've listed just a few here. You may come across quite a few individuals that have multiple of these. So you could have somebody that's coded as having global developmental delay. They could be, or they could have gone to a school with a EHCP care plan, or they could have had attended a special needs school, SENCO. You've got individuals who have got Down syndrome. They may also have a learning disability associated with it. You've, like we've mentioned, autism, Asperger's. We've got Williams syndrome, Fragile X, cerebral palsy. I've also noticed going through Arden's caseloads, case finders, that a lot of individuals with cerebral palsy have been picked up by Ardens. A lot of the time they won't have a learning disability and they live very independent lives and attend mainstream services. You may come across individuals with behaviours that challenge. There are a lot of different technical words, so you might find coded challenging behaviour or quite a few old words that I try to remove because I just think they're quite offensive, but generally behaviours which challenge is the current go-to definition for that. You've got Rett syndrome, Prader-Willi, NF1, fetal alcohol syndrome and missing chromosomes. It's important to know, especially when you're doing annual health checks or if you're doing those annual health checks, that depending on their conditions, they need additional health checks with it. So individuals with Down syndrome are more likely to get early onset dementia, usually around 50. So something to look out for, and for any of their carers or family relatives that are looking after them or supporting them. They also need an echocardiogram in their adult life, so it's something that you need to check that they've at least had. People with cerebral palsy are more at risk of being vitamin D deficient because their bones don't quite develop as well as they should. So always need to add on a vitamin D blood test. They may have musculoskeletal problems, they may have excess saliva. So there's lots of different things for all of these different conditions that need extra additional support than what you already give. I will be providing a whole resource list with a lot of the conditions that are on here and the extra support they need. It was available on a link through the Royal College of General Practitioners, but they've resorted their website and I've lost the links. So I've got them downloaded and I will attach them all to an email at the end. Health inequalities. So people with individuals with learning disabilities will face health inequalities, hence why it's there's the leader report, so into premature deaths and why they're dying, and they will have worse physical and mental health than people without a learning disability. So I put on here, on average, the life expectancy of a woman with a learning disability is 18 years shorter for a woman, and then 14 years shorter for a man. So that's quite shocking, I would think. There's the confidential inquiry into premature deaths of people with a learning disability also found that 38% of people with a learning disability died from an avoidable cause, i.e. constipation, compared to 9% in a comparison population of people without a learning disability. There are a number of barriers that stop people with a learning disability from getting good quality healthcare. Some of those could be accessing the practices, accessing support, going to groups. Trying to get onto a bus can be quite daunting. You don't know sort of who could be on the bus and it's going to be really noisy. So that could be really off-putting. They simply might not be able to afford it. There could not be enough people trained at your practice or out in the community on how to support somebody with a learning disability. Again, the individual might not even be identified as having a learning disability, and therefore they might be patients that you don't see that often. But if you got them in, had a chat with them, and you probably went through the inclusion tool, you would find they probably would meet a lot of that criteria. It might be something you need to look into to try and support them better. They could just be a lack of joint working from different care providers. So they may have switched through sort of job centre, lots of other providers, and actually not been identified or picked up. A lot of the time, they might not be able to communicate their needs. I'm sure you may have noticed some individuals with more moderate to severe or who are non-verbal may, for example, be banging their head a lot, or they could be doing any sort of head things, so lots of this, or holding onto their ears. It could be their way of expressing pain, and unless somebody knows them very well, you're not going to be able to identify that. And so if somebody comes or you visit them at home and they've got sort of a change of behaviours and you're not quite sure what's going on, it can take a big team of people to try and work out what the basic steps are. So it's usually sort of a top-to-toe assessment, find out what's going on. So there's sort of some of the reasons why they face health inequalities. How can we stop them? So there's loads of things that we can do to stop health inequalities. So I just start from top to bottom. So the first one is just to review your learning disability register. So I spent a long time going through the Ardens case finder. Managed to pick up about 10 so far of 250. Haven't finished my way through, but 10 of them have got a learning disability and they were just coded inappropriately. I've probably got another 50 that probably have a learning disability, but we need to talk to them and probably go through the inclusion tool. I've had quite a few meetings with the community learning disability team. Jenny Rosser is the lead nurse within South Gloss for the team, and we've spent a lot of times going through their register, our register. We've got people that have fallen off the register or simply moved out of the area. They haven't updated their notes, vice versa. And again, we just need to ensure we're using the correct read coding and standardise it against the whole of the nation. So that is the on the learning disability register code. The next thing we can do is invite individuals to annual health checks. Lots of important things within that. I'm quite proud of the work that we do with our annual health check at Green Valleys. We've got our wonderful HCAs who do all of the preliminary or pre-assessment. So we'll be checking height, weight, waist measurement. Waist measurement usually is quite left off in general assessments, but it's a good way to indicate whether they may be at risk of cardiovascular disease. So the reviews I've done this year, we've noticed waist has increased, but the weight has remained stable. So there's a lot of work around exercise and things like that. Checking blood pressures, we do blood tests, we take a urine sample to check for any protein in their wee as an independent risk factor to having problems with their kidneys or anything else that's going on. They then come and see me, and they will be seeing a few of the other nurses eventually. And we do a top-to-toe assessment. So we do a mental health review, we do all the individual health checks. So if they've got Down syndrome, cerebral palsy, Rett syndrome, we do all of those specific checks and then the others. And then they go and see a GP, and the GP will do all of the physical examination. So they will check their ears, they'll listen to their heart, they'll listen to the respiratory system, they'll check the abdomen for any signs of constipation or any additional obstructions, and then they will also offer a breast or testicular screening. And we've picked up a lot from health screening. We picked up a couple of that would have been had been left for ages. We picked up quite a lot of low moods and safeguardings regarding sort of where they're living, and just day-to-day things sort of that you would pick up with the general population, undiagnosed diabetes, anemia, that sort of thing. So really good base to sort of stop those inequalities from happening. Cancer screening is a big one, and there's a real push within the CCG in our area, so within BNSSG, to improve our cancer screening uptake. So Leslie Lapine is the CCG Commissioner for Learning Disabilities and Autism. She is a nurse by background, working and supporting with individuals with learning disabilities for her entire career. She is trying to improve the care that we give. She is currently trying to bid for some boobs and testicles that have anatomical models that have got cancer on them, because I'm sure individuals without learning disability like myself, I don't necessarily know what a lump or a bump feels like, and so how do we try and explain that to somebody with a learning disability to check for themselves or their care team to support them. And then I think the plan will be, once that's secured, we'll loan them out across the practices and we can set up other things. If you're struggling to get patients to attend cancer screening, find out why, what's the problems. A lot of the time it will be, or from my experience, it will be care staff. They don't have enough staff to take them to the appointments. The individual just doesn't want to go, doesn't understand it. That's where I'd contact the cancer screening teams directly. So the breast cancer team at Southmead, they run their own clinics, one for individuals with wheelchairs, so they've split them, which seems a bit bizarre, but they've got a wheelchair accessible clinic, and then they've got another clinic for individuals with a learning disability where they spend more time. And if you feel that something's really important and this individual really needs to get a check, more importantly than other people, you've got the usual methods. What I would suggest is, whenever you're referring somebody into hospital, whether for a day case or review, make sure that you also let the community, the hospital learning disability and autism liaison team aware. They'll be aware of that individual coming in, and they can set up social stories, they can do tours, they can help build that relationship and make coming into hospital so much easier and more comfortable for the individual. The other thing to pick up on is immunisation reviews. So I always check at the annual health checks, and it's taken me about 18 months, but I've finally managed to mass vaccinate 2 of our care homes who were not covered for MMR or diphtheria, tetanus, polio. It took me a long time, I had to go through paper records, hence why it's taken so long, and then do best interest meetings and capacity assessments. But they're all now vaccinated, or at least the ones that are appropriate. And so hopefully if there's a measles outbreak in one of the care homes, it shouldn't affect them because they are vaccinated. Again, with your flu, your COVID, pneumonia, shingles, generally they can be forgotten about. So it's just making sure you capture them as and when they come in. I've noticed more and more frequently that epilepsy reviews, mental health reviews, carers reviews aren't really being done, probably because there's just a lack of appointments. Epilepsy review can be quite straightforward. You're finding out how are their seizures, what are their patterns, and so I've got a patient at our practice who was completely seizure free when I reviewed him last year. This year he's had 2 seizures a week, maybe more, with 11 hospital admissions. And so it's finding out what's going on. Do we need to refer? So it's good things to check out on, including individuals, carers, family, friends with all of their health needs, and accessing services. Just make sure that they are all included because they're really important to the individuals, just like I'm sure your family and friends are too, and they may have a really good relation support. Using reasonable adjustments. So I, or every individual at our practice has who has a learning disability and is on our register. As soon as you go into their notes, there'll be a pop-up alert. I'm sure you use it for other things, but ours will always have something about their reasonable adjustments. So if they come into the surgery and actually we're running a child clinic that day, and there's a lot of crying babies, a lot of noise, then it will say on the screen, actually this individual can't tolerate that noise, or a busy waiting room, please offer them somewhere else to go and wait, so they can go and wait in another clinical room or another reception area. It might be that they've actually got a really high pain threshold. So if their carer or themselves are calling in, say, look, I've got a headache and I need something. Actually, if they've got a headache and they're complaining about a headache, they probably are really quite unwell. So please take more alert of that. It might be that they have given permission for a certain relative to or carer to access their medical information. So it's just important that that's on there for your reception team and anybody else accessing their records, that they know who they can and can't talk to. And that's reviewed every year at their annual health check. So it's lots of really useful information like that, really, and how we can best support them. And then again, just seek support and build relationships with everybody that's available. So they may have an IMCA, so an independent mental capacity assessor or advocate, and that'll be a key contact to just make sure that if you're making any decisions that they're involved with that as well. The community learning disability team, the hospital liaison team, and then within our network we've got a LD GP lead, and she's wonderful and very helpful. So it's just sort of seeking out really in your PCN who are your key contacts. Any questions? I appreciate I've just talked to you a lot. Okay, I'll move on.
Ask a quick question, because a lot of these things aren't on the checklist for the checks, because normally it's just height and weight, and you do a lot more, it seems. You know, there's cancer screening, these other reviews, the epilepsy reviews. So every year they're seen by an HCA, yourself, and a GP. Is that right?
So they're seen by HCA, me, and a GP. Yeah, just the pure basic. We call it an hour to save your life.
Do they come in once and you just have the back-to-back appointments? Do you do the HCA, then the GP straight after?
Yeah, because it's difficult to get people in for appointments anyway. So to call, and a lot of the people that we see in practice have jobs, they have got a very busy schedule, and so coming in for multiple appointments just isn't really feasible for them. So yeah, our templates are all scheduled up, so they are. They start from the HCA, then they see me, then they see the GP. Depending on what template you use, I don't know if you've got Ardens. I'm not an advocate for Ardens, I'm not paid for them or anything, but their template for learning disabilities include all of this.
Brilliant, thank you.
Brilliant, thank you.
That's all right. Any other questions? No, I'll move on. So communicating, I think a lot of people when they first meet or come into contact with somebody who's got a learning disability think, I don't know what to do, I don't know how to talk to them. Just talk to them, see what response you get. One of the main things I probably would say is just be yourself and make sure that you leave a long enough time in between asking a question or making a comment before you move on to talk about something different, just that it gives somebody the time to sit there and listen and understand and then communicate what they need. So I don't know how we're doing for time. Not long left. Okay. I had another task for you, but I will skip that. So you might have heard of easy read information. Easy read information is basically lots of non-jargoned, or you've got a document and it's really, really wordy and I don't even understand it. So you pick out the key points from it, you break it down into very small sentences, increase the font size, put a standard font. So as you can see here, Arial is really easy to read, but if you use this font, that's quite hard. And for somebody who may have problems with their vision or just try to understand that, it can be really difficult. It's making sure that you do no more than sort of 10 to 12 words in each sentence, and no more than 4 to 5 sentences per page. You would think people would be really good at making this, especially the Avon LMC. I'm not digging them out if you are here, but they created a really, really, really poor privacy notice about 2 years ago. And it wasn't an easy read at all. The whole page was filled with sentences and wording and black and really stupid pictures that were completely irrelevant. And so I sent it back to them. I said, I think you might need to go and amend this. And they did. And we've got a lovely, beautiful one that they amended last month. So that is available. But it's just picking out the key details, really. Making sure capital letters are used correctly. So don't put them in random sentences where they shouldn't be. Using headings, so where I put here communication, what we're talking about, and then identify. Put information in bold, so if you're talking about easy read about cancer, bold word, none of the others need to be. And then what does cancer mean? And identifying and using non-jargon information, really. Using bullet points, use page numbers, 1.5 line spacing. So this information here, this is too much for one page. If this was an easy read. The words are all close together. It's too much on a page. And again, these pictures are completely irrelevant to what we're talking about, okay? Obviously, everything in non-jargon, so really simplify the text. What does it mean? So you could talk about diabetes all you like, but they might not know what that means. So you can basically say it's an illness caused by too much sugar in your blood. Use really short, clear sentences. Avoid putting more than one idea in a sentence. And use numericals, so 1 instead of the word 1. And then pictures need to be clear and large. 1 image for each important point. You don't need to fill that page with images. You want a picture of a real apple rather than a cartoon apple, because a lot of the time they won't identify between a cartoon image of a real life item. Obviously, if it's something like Mickey Mouse, there's not necessarily a real life Mickey Mouse. Mickey Mouse is a cartoon. So it's just making sure that you're using appropriate images. There are a lot of resources online. I would urge you to go onto the Facebook groups. There's so much easy read information that's been provided by other practices, other trusts, and it saves you recreating the wheel. There's also a website called Easy on the letter, and you can use all of those pictures, and they are approved. It's free, and it's an NHS trust, and you can download them all and add them into your information. So that's all about sort of that communication. And then there's other ways to communicate. So I want anybody to just unmute and tell me one way of communicating in general. Go.
Body language.
Lovely. Next.
Facial expressions.
Perfect. Yes. Nice. What else?
I use my hands a lot.
Amazing. Me too. What else?
And we use diagrams.
Yeah, perfect.
Space, how much space you give between someone and where you're standing.
Yeah, amazing.
Environment.
Yeah, good. What do we use a lot?
Telephone.
Technology. Yeah. So you've got your verbal and non-verbal. You've got variety of body language. Children are taught, not all, but children are taught Makaton, and that can continue into adult life. So probably just finding out key words to communicate. My favourite one is hamster. So it's just finding out different ones. I know cake. Basic sign language. I haven't actually met an individual with a learning disability who use basic sign language, but definitely have a look and see what they use. There's things called intensive interaction. You've got your gestures, your vocalization, your facial expressions, objects of reference. So like people have said, objects pointing to diagrams. There's things called talking mats. They're usually done by or set up by the community team, but you can find out how it's used. Audio and film, technology, social stories. So there's quite a lot of different communication. Yeah, lots of people use them differently. Different access to services. So what's available in your area? So within the community learning disability team, you've got your behavioural nurses, your community nurses, your occupational therapists, physiotherapy, psychiatry and a consultant psychiatrist. You've got psychology, and I'm sure you've got other teams that I've forgotten about. I work quite a lot with the behavioural nurses because, for example, I had an individual who she had Down syndrome, around 50, so we're thinking maybe dementia. Complete change of behaviours. She started stripping off her incontinence pads and her trousers. She'd be flying faeces around in the corridors, and she slept throughout the day and would wake up at night. So we were thinking maybe dementia pathway. Really needs bloods. She also had a problem with her thyroid, so she was on thyroxine medication. She hadn't had a blood test for 20 years, and she would absolutely not allow us to do it. We tried diazepam, we tried lorazepam, all sensibly and within risk assessments, didn't touch her. So I referred to the behavioural nurses to find out, look, we really need this blood test, one for the dementia pathway, but two, find out what's really going on, because it could be anything. And we're thinking more sincere than, but it could be something very simple, like she could be anemic or deficient in vitamin D or something like that. So we got the behavioural team involved, and we did a best interest meeting. We agreed it was in her best interest to support with a clinical hold, and we took the blood test. Took a few attempts, but we got it. And it turns out that we were over-treating her with her thyroid medication. We reduced that back in January, and she is a completely different woman. She smiles a lot, she's lost loads of weight, she's walking around the corridors, she's enjoying day-to-day life, sleeping normally. So it's really thinking outside the box. Just because something can't happen, it can happen. We just need to work out a way of how we can do it and how we can support them and what is in their best interest. So just communicate with people, reach out to colleagues and say, look, I wish we could do this. Well, why can't you do that? There's lots of people around that can definitely support you and do what's best for the individual. Again, talked lots about them, but the hospital liaison nurses specifically at Southmead are incredible, a great team. They now work 7 days a week, 365 days a year, and I think they work 12-hour shifts now. When I first qualified, they only worked Monday to Friday, 9 till 4. So it's grown massively. BRI, they've got a wonderful team. They've got Lorna, I think she was the lead there. You've got your PCN GP leads. You've got CAMS, you've got Kingswood Hub if they're under 18. You've got the IMCA, and then you've got social prescribing. Although I am aware social prescribing is about 6 months delay at the minute, but you can put the referral through. I know I'm rushed for time, so I'll carry on going quite quickly. Apologies. So then reasonable adjustments and accessible information. So it's our legal duty under the Equality Act 2010 to provide reasonable adjustments and accessible information. Reasonable adjustments can mean alteration to buildings by providing lifts, wide doors, ramps, tactile signage, but it also means changes to policies, procedures, staff training to ensure that services work well for people with learning disabilities. The NHS decided about 5 years ago that there needs to be standardised training across all trusts and anybody working in health and social care on supporting an individual with learning disabilities. The mum of Oliver jumped in and fought for the campaign to be named after him and the poor care that he received, and ultimately died because of the poor care he received in this area. So that will be coming into introduced. There's lots of information on ELFH. I know that I've got some of the girls, my colleagues are doing that training. I also provide sort of 3 monthly training within the reception, the navigation team, on them and what the alerts mean and how they can support them. I think that, yeah, that's my last slide. And then these are just some of the resources, but I've got a whole load more if anybody needs anything. I'm aware that took a very long time. So that was a lot of talking also. Does anybody have any questions or want to make a comment about anything? Please put your hand up, go right ahead. No?
I just thought it was brilliant. Thank you very much, Liv, for that. I thought it was really informative, especially knowing what is accessible to people with LD, how to speak and communicate and things like that. I thought it was an amazing and really informative. So thank you very much for doing that.
That's all right, not a problem. Anybody got any general questions apart from that? Or anything that they're struggling with, or? Wonderful. So I will send out the presentation just so you've got some key points there and things just to go back on. I will try and attach every single easy read resource that I have. So with big email, it may end up having to be split into 2, but I'm all about sharing resources. There's no point in remaking the wheel, and it's taken me 6 years to get all the resources I have. So if I can just share them with you and make your life so much easier. I have got a whole list of key contacts available. I think I've sent some to Vicky, so she can share them as well if need be. I will double check with them all that they're happy for me to share their contacts with you, otherwise they might be utterly bombarded. But yeah, lots of really key contacts, lots of information out there. And just, yeah, keep going.
Oh, thank you.
You're welcome. Good to see you all.
And is it okay, Liv, if I've recorded this? Is it okay if we put it on the, we're going to share it with a lot of the care coordinators who couldn't attend today?
Yeah, of course. Just apologise in advance, it's just me waffling a lot.
No, it's been brilliant. Thank you.
You're welcome. Have a good rest of your day.
Bye.
Bye.
Thanks, bye.
So that was brilliant, everyone. So that was great. If you could just pop me an email and let me know if you want to do another meeting on the 7th, I think it's Wednesday the 7th, just to talk about care and support plans or anything else that you would like to. It's not formal training, but just so I get a gist, I'll send an email out to everyone. But other than that, I think that's everything, unless anyone's got any queries for me or for anybody else.
Sorry, Vicky, did Liv say that she did training for health navigators? She did it.
Well, she did tell me she is leaving the NHS actually. So I don't think she's going to be around that much longer. So I'm not sure. Who are you thinking of the training for, Tracy?
The team to actually identify, because I get a lot of hassle where they just think people are being really angry and horrible and they don't read things and identify the signs. So it's just, and we've got a lot of new staff ahead, about 6 new staff. So, and we've now got an assistant ops manager who's doing personal one-to-one. So I'm just thinking if they could incorporate that now,